Welcome to Raaonline. Today's topic is postpartum hemorrhage. So when the baby is at the zero station, it has to be at the level of the ischial spines. The biparietal diameter is at the level of ischial spines when the baby is at zero station, and when the baby thinks from here onwards it's going to be all right and baby will be on its way out. So there are various problems which we can face ahead. So of the various ailments of pregnancy, today we are going to discuss the postpartum hemorrhage of pregnancy. The other problems like gestational trophoblastic disease, hypertensive disorder, hydramnios, hyperemesis and incompetent cervix will be discussed elsewhere. So maternal mortality rate in India is maximum in the states of Bimaru, that is Bihar, Uttar Pradesh, Madhya Pradesh, Rajasthan and Odisha. So PPH is the most common cause of maternal mortality. It accounts for 25% of all maternal deaths worldwide. And in India, the percentage of maternal death due to obstetrical hemorrhage in India, it is 38%, Africa 33%, Asia 30%, Latin America and Caribbean 20% and other developed countries 13%. So in India, we find a lot of cases of postpartum hemorrhage leading to maternal death. How do we define it? It is defined as vaginal bleeding of more than 500 ml after childbirth. Now, when we use this definition, we should realize that bleeding is underestimated because visual quantification is difficult. Bleeding is mixed with other fluids like amniotic fluid and urine, and therefore we don't know how much is the blood loss and how much it is mixed with amniotic fluid and urine. Bleeding can also occur in postpartum hemorrhage slowly over several hours, and the condition may not be recognized until the woman suddenly enters shock. Most commonest period when women die is in the postnatal period, and the leading cause being postpartum hemorrhage. So 74% of maternal deaths happen in the postnatal period, 4% happen during labor or in the intranatal period, and 22% happen during pregnancy or the antenatal period. Causes of maternal death: PPH is 20%, heart disease 16%, thrombophlebitis 15%, pregnancy-induced hypertension 8%, septicemia 6%, anemia and malnutrition 4%, jaundice 4%, postoperative complications 3%, rupture uterus 2%, antepartum hemorrhage due to placenta previas and abruptio placenta 1%, bad obstetrical history 1%, and prolonged and obstructed labor 1%, puerperal psychosis 1%, HIV and AIDS in pregnancy around 0.5%, abortion-related complication account for 0.4% of maternal death, arrested breech accounts for another 0.4% of maternal death, and diabetes accounts for 0.29% of maternal deaths. 47% of maternal deaths in rural India are attributed to excessive bleeding and anemia resulting from the poor nutritional practices. So why there is a high mortality in PPH is because we fail to adequately recognize volume of blood loss, we fail to provide adequate resuscitation to the mothers, and we also fail to provide timely treatment for the cause of PPH. And remember that PPH can kill within 2 hours of its onset. If we were to see the mean interval from the onset of the problem to the death, we will realize that postpartum hemorrhage leads to death in 2 hours. Antepartum hemorrhage due to placenta previa and accidental separation leads to death in 12 hours. Rupture uterus lead to maternal mortality in 1 day. Eclampsia leads to maternal mortality in 2 days. Obstructed labor will lead to sepsis and shock and death in 3 days. And sepsis will lead to shock in 6 days. What are the risk factors for PPH? If a person had previous history of PPH, if the patient had over-distended uterus due to macrosomic baby, or because of polyhydramnios, or because of multiple gestations, or because of other medical disorders associated with pregnancy like preeclampsia and anemia. However, 2/3 of postpartum hemorrhage occur in women with no identifiable risk factors. What are the 4 T's of PPH? So, commonest cause of postpartum hemorrhage is T, that is atonic PPH. So, T stands for tone, trauma, tissue and thrombin. Atonic PPH is responsible in 70% cases of PPH. Traumatic PPH is found in 20% cases of PPH. Tissue or retained products of conception or retained bits of placenta is found in 10% cases of PPH. And coagulation disorders or thrombin is the cause in 1% cases of postpartum hemorrhage. First, coming to the tone. Uterine fatigue caused by prolonged labor or overuse of oxytocin for induction. Precipitate labor can lead to atonic PPH. Overdistension of uterus like polyhydramnios, multiple gestation, macrosomia can lead to atonic PPH. Retained bits of placenta also can lead to uterine atony. And higher order births like in multiparity can also lead to uterine atony. Retained bits of placenta or products of conception is called as tissue. It can lead to postpartum hemorrhage in 20% of cases. Trauma is ruptured uterus or genital tract or perineal lacerations or extended episiotomies that can lead to postpartum hemorrhage in another 10 to 20% of cases, and thrombin or bleeding disorders can be responsible for PPH in 10% of cases. So how do we assess and manage the patient initially? We call for help, mobilize the personnel, evaluate the woman's condition including the vital signs, pulse rate, blood pressure, respiratory rate, temperature, and if shock is suspected, immediately begin the treatment. Patient for PPH should always be catheterized to do the input-output charting. Patient should be given uterotonics in the form of oxytocin 10 units intramuscular. Uterus should be massaged to expel the clots, and we do a bedside ultrasound to see that the uterus does not contain any placental bits. Give IV fluids to the patient and examine for the completeness of expulsion of placenta by doing a bedside ultrasound. Then bring a light source near the foot end of the patient and under good illumination examine the cervix, the vagina and perineum for tears. Current approaches for preventing postpartum hemorrhage include active management of third stage of labor, which advocates the use of prophylactic oxytocin with the delivery of anterior shoulder of the baby, that is even before the PPH has begun. Give 10 units intramuscular oxytocin. Early detection of hemorrhage by using the simple techniques of measuring the blood loss, and anti-shock garments, that is also called as a non-pneumatic anti-shock garments, and these are used to resuscitate and stabilize a patient for up to 50 hours till the patient is being shifted to a tertiary center for comprehensive care for PPH, and shock is available at the tertiary center.